I think it started. It's trying to start. Give it a second. Okay, now we're. All right, so today we're going to go over Chapter 8, which is movement, motor control, sensation, wounds, and pain. Again, I'm not exactly sure why they put all this together. There's just so much. We're going to do half today and half on Wednesday. And we're just going to go from this screen because it's not going to work. All right. So again, you should read Chapter 8 before coming to class today. There's all your learning objectives and even some self-assessment activities for you guys to go over. Let's go first, page 157 in your books. First thing we're going to talk about today is basal ganglia disorders. Basal ganglia disorders impact clients' coordination. So if I'm talking about any of these disorders that are on this slide, we are talking about a coordination issue. What is the difference between coordination and movement? What makes coordination what it is? Synchronized, that's one way to kind of think about it. Precise. It's precise movement. It's purposeful movement. There's a purpose to whatever they're doing. The basal ganglia is involved in regulating movement patterns and automated movements like walking or riding a bike. See, movements are initially something that we have learned, but these movements become more automatic with time. You know, you don't sit and think every step you're going to, all right, left foot, right, oh, I'm losing my balance, let me stand up. You don't do those kind of things. Those are automatic movements, right? We've already got to that point. I'm going to review really quick what these are. On 157, it's table 8.1. And then we're going to go through and I'm going to call on each one of you. You're going to match it with whatever it is. Got me? Cool. All right. The first one, I really can't pronounce this. I'm going to try. It's hemibalismus, I think is how it's pronounced. Sorry. That's violent thrashing movements of the opposite extremity. In case this be wanting to initiate movement in one and having uncoordinated movements or doing a motion with one and then having uncontrolled movements in the opposite extremity or thrashing looking movements. Athetosis, this is slow flailing of the upper and lower extremities, including continuous movements, often twisting or even worm-like. So it's kind of like this motion here. Okay. You have chorea. This is sudden involuntary jerky motions, usually of the axial and proximal limbs, like shoulder shrugs, hip movements, facial grimaces, crossing and uncrossing of the legs. Movements appear dance-like, especially if it's me dancing. I'd probably look like that. All right, dystonia. That is sustained muscle contractions that produce repetitive twisting movements and abnormal posturing. So this is where someone is really, really tense. Their muscles are really contracted and their movements are very jerky looking, twisting because their muscles are contracted. Dyskinesia. This is rhythmic, repetitive movements. This is where someone might do like the hammer that we talked about with the Tulia tests. And they keep doing it like they have problems stopping doing the movements. Tremors. This is, there's two different types. A regular one is an involuntary movement caused by alternating contractions. So this is, you know, just like a jerk. It looks like a jerk when you think of it, like Parkinson's looking tremors. A resting tremor is something that occurs while a client is at rest. They often go away when the movement is actually starting. So they may be sitting completely still and having a tremor, but when they start to initiate a movement, the tremor goes away. That's resting tremors. Okay? Lastly, is tics. This is repetitive, brief, involuntary, purposeless movements. And it can involve one muscle or group of muscles. So it's kind of like, you know, if they have a tic in their neck, they kind of will do that number there. It's involuntary. Okay. All right, so let's match them up. Maggie, athetosis. Which one does that match up with? What is it? The slow flailing movements, yep, of the upper extremities and lower extremities. Yep, very good. Allie, dyskinesia. Very good. Coria, Jennifer. Very good. Meredith, tics. Was it?
The first one.
The brief, repetitive, and non-purposeful movements. Very good. The one I can't pronounce, Isaiah. There you go. That one. Hemibalismus, I'm pretty sure is how it's pronounced. But. Yep. Very good. Resting tremors. Wait. Cool. I don't think I missed any of them there, did I? Maybe dystonia. Did I do that one? Someone want to just hit that one for us, the last one? Yep. Yep. Very good. It's the, the muscle is contracted, the movements look twisty and jerky. Very good. Awesome. So what are some treatments for these? These are all going to be very important, okay? Providing increased sensory input is one of the most common and effective treatments that we do in occupational therapy. How is that done? You can either do like different textures to provide sensory input. You can start with something soft and then move to something very rough. Weight bearing. We've talked about weight bearing a lot. With movement disorders, weight bearing is massive because if the arm is just kind of sitting there, there's not a lot of sensory input. If you put weight through it, there's constantly signals going from the muscles to the brain of saying, hey, this arm is here. And your brain wants to work and wants to move that arm in a normal movement pattern. But, the basal ganglia is kind of, jacked up, so it can't. How we do that is that sensory input. Okay? Some other stuff is some comp strategies, home and environment adaptations, adaptive equipment. You always want to help stabilize the patient proximally. Okay? So when you're doing like range of motion, or if you're needing to do a splint, or kinesiology taping, whichever, you want to stabilize their movements proximally to distally, okay? Working your way from proximal to distal. Why would you want to not work distal to proximal? So if I have these jerky involuntary movements, okay, why would I not start at the hand and then work my way to shoulder? Why would I start with the shoulder and work my way down the hand? Yep. So ahead in the chapter, we talk about what's called movement synergy patterns, and that is how we're going to help release contractions and things. Your body, these are normal movement patterns that your body moves through. Okay. Starting out proximally to distally, you hit those patterns way better. Cool. Awesome. Another thing we're going to do is work on muscle strength, range of motion, and then splinting if they're contracted. Okay. If they've, like we've talked about with the muscle contracting so much. Any question on basal ganglia disorders? Are we good? Okay. All right. Cerebellar disorders. Gosh, whatever. Those are also on page 157, table 8.2. Okay. The first one is asthenia. Asthenia is listed right there. That one is described just as pretty much muscle weakness. Okay. Ataxia, that is uncoordinated movement patterns. This, in fact, affects their gait, their posture, and upper extremity coordination. Initiation of movement can be delayed. They're going to have a lot of difficulty walking a straight line. tending to move toward the side of wherever the lesion is, wherever the injury was. Is diatokinesia. That one is difficulty performing rapidly alternating movement. So saying, you know, right hand to your nose, left hand to your nose, and alternating. I have a lot of difficulty with that. Dysmetria is difficulty judging the distance needed for movement. This is, you know, saying that I need to step up this far in order to, you know, make this stair happen. These disorders all involve the awareness of your own position in space. Okay, so knowing where your hand is without having to look at it. Like right now, Maggie, tell me, where is your left foot? Where at? Tell me more about it. All the information you can to describe where your left foot is. Okay. Now you're not seeing that, right? But you know where your foot is. Okay. That is what we're talking about. These all disorders affect that, where your body is in space-time without having to look at it. The information that is received to the cerebellum and the joints is how we know that. So your joints, your muscles, me sitting in this chair, I know that my, you know, hips are slightly flexed. I've got my feet kind of pointed outward. I know all that because my joints and muscles are constantly sending feedback to my brain, telling me where those things are. Okay? Cool? All right. Dysenergy, that one is the movements are broken into segmented, jerky, and uncoordinated movements. Often called movement decomposition. It's almost like you're taking a normal movement pattern and they're breaking it into segments and just doing like one part stop, one part stop, one part stop. Okay. Motor impersistence. This is when someone is trying to maintain bilateral upper extremities in a fixed position. The affected extremity will move out of position without the client noticing. So you say, okay, look straight ahead, put both arms out to the side, and then all of a sudden one starts to go down and the client doesn't even realize that that's happening. Okay? And then rebound phenomenon. That one is the opposing muscle groups are not regulated accurately. So, you know, the same like the tricep and bicep, they're kind of alternating of each other. They're, you know, you might have the tricep contracting at the same time the bicep, and then the arm's not going to move. Cool. All right, same thing we're going to do here. Faith, what is asthenia?
Uncoordinated. Oh, asthenia, sorry.
Yep.
Muscle weakness.
Yep, that one's just muscle weakness. Cool. Allie, ataxia.
Uncoordinated movement pattern.
Okay. Gotcha. Dysdiakinesia. Maggie? Rapidly alternating. Yeah, that's important to know the word rapidly with that one. Okay. Jennifer, dysmetria. Yep. So that errors in distance movements. Yep. All right, Isaiah. The next one, dysenergy. Sorry.
Wait, I just did that one.
No, you did dysmetria. Dysenergy is different. Dysenergy. Yeah, I call it dysenergy. It just makes it easier. What's the other name for it? Ah, there it is. There it is. Cool. Meredith, motor impersistence. Look at your book there. Page 158. It's the second one down. What does it say that they have difficulty doing? Okay, so which answer there would... Remember what I looked like whenever I said what that one looks like? What was the little demonstration I did? Someone want to help her out with it? Yep. So that's where they have, like, if you ask them to hold both their hands out and they're looking in front of you, and then they drop an arm and they don't even know they're doing it. Okay. And you have to be able to say, like, you can't tell them, all right, hold your hands up there for 5 minutes, because then we're all going to be like, okay, you know. But this is, they put them up there and then they're looking, they're not really understand or not realizing that one arm is going down. Okay. Intention tremor, Maggie. Did I talk about that one? Oh, sorry. An intention tremor is when the movement is initiated and tremors diminish at rest, but movements often intensify toward the end of the movement. So this is where they might not have a tremor until they get to, like, right here when they're trying to open the doorknob, or they're going to feed themselves and they get almost all the way up that normal move and then they start having the tremor. Okay. I kind of answered that one for you guys. All right. Rebound phenomenon. Maggie. Okay. So dysregulation of opposing muscles. Cool. Awesome, awesome, awesome. This one makes things like buttoning a shirt or any kind of other functional movement very difficult. Okay. I don't have, you guys are more than welcome, and I encourage you to go onto YouTube and look up some of these disorders, because if you put videos with it, way better. Okay. If you can actually see it. There's just so much to go over. I don't have enough time to show you guys individual videos for each of these, because we would spend all day just watching videos. Go on when you are studying and look up videos on YouTube of each one of these. Okay. That way you can see exactly what it looks like. But yep, you need to know exactly those tables like the back of your hand and twice on Sundays. Okay. That didn't make any sense, but you get the gist. Right? Those are very, 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 very important to know. Yep. Yep. They can, but you need to know the distinguishing what makes them different. Just because someone has jerky movements, that could mean two, but where is the jerking happening? Is that the tremor starting to happen when they get at the end of the movement? Is it happening at rest? Is it happening the entire movement? That makes it different, right? Got me? That's why I was saying look up videos of it, because it will really make sense when you see it. But there are a lot of questions coming from those two tables. Okay? And it's just really good information to know going forward. If you see a patient who is having a tremor at the end of a movement, you should know, hey, you know, I know what that is, and move forward with it, okay? A tremor is the same. A tremor itself is the same under both. What's different is there's a resting tremor, which is caused by basal ganglia disorder, and then the intention tremor that happens at the end is the cerebellar disorder. Does that make more sense? Yep, tremor is a tremor. Yep. What makes it different is when is it happening at rest or is it happening at the end of a movement? That's when it, you know where is causing the disorder. Okay. All right, cool. Next, some of these other motor coordination. Let's kind of put our feet to the fire here. So your client tries to put a coin on a vending machine and misses the slot several times. What area of the brain do you think is affected? This is an example test question. Why?
Get things like end of an intentional movement.
Yep.
And also errors in the distance. They probably, if they get so far away, they're just like missing the slot.
Very good. Very, very good. Awesome. So what are some possible disorders? So now that you know it's cerebral, what are some of the possible disorders that would make something like that difficult? Go back to here. I'll go back to the disorders. What one or multiple of these would make that difficult? Why would an intention tremor make it difficult?
Like you just said, it's at the end of the movement.
Very good.
of putting-
Awesome. Very good. What's another one, Maggie? Why? Perfect. Very, very good. What other ones? Meredith, which one of these disorders can you say would affect that? Hmm? Dysdiakinesia? Okay. Why would that affect it? That's difficulty performing rapidly alternating movements. Why would that be? Why would that affect a patient being able to insert a coin into a slot? Not necessarily. It's alternating movements. I don't think that one would really be. You want to give it another shot? What's another disorder there that might be? Or can anyone come up with another one there that's on our list? Motor and persistence. Why? Maybe not. So that's where both extremities are doing a motion in a fixed position. So when you go to insert a coin into a slot, you're not, using both hands, right? That's kind of a singular thing. Okay. Yep. Bilateral. And that's where one just kind of drops and you don't really realize it. What? Yeah. Absolutely. So one definition I forgot to mention to you guys is praxis. Praxis is movement when we're talking about it. I wrote it down. I think your book defines it maybe a little different. Motor. Your book defines it as motor planning. Same thing as movement. So being able to think about what movement you're going to do and actually perform it. Okay. That's one you're also going to want to know. All right. So when trying to eat, your client's upper extremity is shaking and the food falls off the spoon. What area? This one's kind of hard.
Consistent shaking.
Hmm.
We assume you
I would just, for the sake of conversation, however you want to do it. The upper extremity is shaking and falls off the spoon.
Chorea,
Why is it chorea?
sudden jerking motions of
Okay.
axial and proximal.
So what area of the brain is involved there? Great. Awesome. Good job. What's another one? You can definitely make a case for either place here. Basal ganglia or cerebellum disorders. You can definitely talk yourself into both. What's some other ones?
Tremor.
Why?
If they're constantly shaking.
Okay. What kind of tremor would that be if they're constantly shaking? So they're shaking at rest. They're shaking while they're doing the movement.
At rest because they're moving.
Okay. So if they're shaking while the movement is going, that's just the tremor. Yep. Yep. Remember, that's the same. That's why I'm saying you can talk yourself into both because tremor is the same. Period. If it's at rest, it's one area though, and if it's the intention tremor, it's at a different area. Tremor across the board is the same. Very good. What's another one?
tremor across the board.
Tremor is the same, but you can't just see a tremor by itself and say that's basal ganglia or that's cerebellum disorders because it's the same defined in both. If it's at rest, that's when it's basal ganglia. If it's an intention tremor only at the end, that's when you're going to see the cerebellum. But a tremor is a tremor. Okay? Got me?
Athetosis.
Why is athetosis one?
It's the slow flailing of upper and lower. Oh, does that have to be at the same time?
No.
Okay. So.
Doesn't have to be.
Flailing upper extremity.
Yeah. So no, he's not just shaking. He's like, throwing. But
Oh,
when it
is that
says
not
flaring,
fun?
it's meaning
Could that be one?
flaring. Absolutely. Why not? I mean, why not? You can't eat if you get almost in it. You throw it. That's absolutely true. So if you let me throw this into a real world example. If you're needing to practice self-feeding with a patient who has something like that going on, or has the flaring of the arms, how do you practice that? Yeah, absolutely, the sensory input for sure. Weight is okay. How do you practice? You actually want to do the act of self-feeding. How might you set that up for the patient? Or some things you might not want to do with the patient. Let me put it that way. Don't overthink this. This is not a trick question. Huh? A stable surface, right? Absolutely. If they do the flare and it knocks over the table, it's embarrassing, right? What's some other stuff you might do or might not want to do? Think about it.
Putting liquids start. Things that
Okay.
are easier to clean up.
Okay, so let me ask you this. Does the patient have to have liquids?
Yes.
Okay, so would you want to avoid liquids altogether?
No.
Okay, so how could you give the patient liquids and it still be an okay, safe, and non-embarrassing environment?
Give them a straw so they don't have to.
Okay, a straw makes the movement smaller, right? They don't have to go quite as far, less chances of a gun. What else?
Cover on the lid.
A lid, absolutely. What else? A handle, absolutely. See, this is all making the act of drinking less involved, right? There's less stuff going on now. They cannot have to close their hand at all. And I'll show you guys some stuff. We'll go over to the lab in a few minutes. I'll show you some common adaptive equipment that we do and use for stuff like that. But like sticking their hand underneath the handle, bringing it up, that's a lot less than, reaching out, bringing it up, twist, and then making sure that they're not shaking and throwing it all over the place. They have a small trimmer or a light trimmer, they can still shake their hot coffee out on their lap, right? So a really good intervention of that would be something that's spill proof, something that has a straw, something that seals when you put the straw in. So that way the heat is kept in, they still get hot coffee, and they're not going to burn themselves.
But what about if you're not a spoon then?
There's a lot of really cool stuff. The weighted spoon is one that's extremely common that we use. They have spoons that will actually self-level themselves. That's very, very cool. I got to see that at conference. They kind of had you do it and like go through trimmers and stuff like mock trimmers, and you can't throw the stuff off. Now, if you go like this, it's going to come off, but regardless. But it will level itself. It's such a cool thing, but they're like $400 and $500 for one spoon. So a lot of money for a utensil. Insurance is not going to pay for a $500 spoon. They're going to pay for the weighted spoon, maybe. That's like $15, but they're not going to pay for something like that. Another thing that I do if they can't do a weighted spoon themselves is I'll have a wrist weight and put it around their forearm while they're trying to eat to do that. And if it's still the trimmer's still going, I'll add a little bit heavier. As long as they're able to lift it and muscle strength is not an issue, the trimmer is the main issue. I'll put more weight on, see if they can do it. I might have somebody eat with a 5-pound weight wrapped around their forearm to go up. And if that helps calm the trimmer down, then we're good. Then you have the act of trying to educate family and educate, facilities and nurses about, listen, at mealtime, this patient needs this wrist weight put on their arm. Our task, something to do. Okay. So we'll go over and I'll show you some of the more common stuff that we use here in just a few minutes. All right. So some different treatment that we're going to do. Increase sensory input to the muscles and joints. This is through the rubbing. You can even do tapping on muscles. You can do vibration, hot, cold, any kind of sensory input helps the brain kind of understand that the arm is there, there's a problem, and helps give sensory input. Some different comp strategies, home adaptations, adaptive equipment, proximal stabilization. We kind of talked about all that stuff. Splinting, muscle strength, and range of motion. So how are we going to test these kind of things with sensory input? Okay, we're going to switch gears to straight sensory stuff now. You need to understand the amount of sensory input they received, or how much are they getting? Can they feel light touch? Can they feel pain? Can they feel hot, cold? What's the issue? Are they able to perceive that input correctly? So are they able to say, "Ow, that's hot," and understand and pull and have the correct reflexes to go with it? And then you also need to understand the effect that impairment is having on how they're able to perform their ADLs and IADLs. The biggest one or illustration to help you understand with sensory how important it is. You put your hand on a hot stove, you automatically pull it away. Ow, that hurts. It's the body's reaction. Some people don't have that kind of sensory input, or it's delayed. How big of an issue is that? They touch something that is hot, they don't realize it's hot, they don't have the reflex to pull their hand away, they have a third-degree burn on their hand. What are some other areas you can think of that are super important to have good senses? Lives to do what? Woodworking, okay. And had no idea that he did it. Wow, it's crazy. Huge thing, right? Because he hit an artery, God forbid, bleed out. He would have no idea that it was going on, right? Crazy stuff. One area we talk about a lot is if you don't have sensation in your lower extremity, you're in a wheelchair, typically spinal cord patient, stroke. Bed sores, huge. They can't feel that normal sensation that you guys get whenever you sit in a chair too long, or you've laid down too long and your arm starts to go numb. I got to move it, They don't have that sense. They have no idea that's going to happen. What that does is it's a lack of blood supply. That's why that happens. And if your body is not getting blood, it decays. That's how it works. So a bed sore is literally rotting flesh. It's gross, but that is what it is. If someone does not have sensation, they need to understand how to move their body on a regular basis, something that we all do without even thinking about it. They don't do because they never get that sensation, right? What are some other areas? Super important to have senses.
I mean, the sense of smell, like if there's a fire in the house, or
Yeah, being able to say, "Oh, there's smoke," sight, seeing smoke, smelling smoke, hearing the fire alarm. Oh, I need to get out of the house. Huge safety issue, right? What else? Meredith. What's a daily occupation? Super important to have something basic that's really important to have good sensation. Huh? Okay, why is dressing so important to have your senses? Like to be able to put on your clothes. What's a safety risk with it, though? Falling is a big one. If you don't know where your legs are in space and time, oh, I have one leg up. Oh, I'm falling. You can't make those connections to help catch yourself. These kind of things sound silly and we take them for granted, but if somebody has an impairment, being able to take into their senses, it's a huge safety risk. Literally everything. Isaiah, what's another area? Okay. Okay. Why is that so important to? Vestibular is not necessarily itself a sense. It's made up of your senses. It's not necessarily, if someone's vestibular system is off, it doesn't necessarily mean they have a sensation issue. It means their vestibular system is off. That's made up by your spatial awareness, your eyes, ears, all of that. Normally, if someone's vestibular system is off their balance, it's an inner ear issue. 9 times out of 10. Someone's like, oh God, and it's just random. They lost their balance and, they're feeling woozy and lightheaded. It's normally an inner ear issue. What's an area? Okay, yeah, absolutely. Why? Why is that important?
I mean, you don't want to go spoil your pants in public.
Mm-hmm. Not be able to feel it.
And also hygiene.
Absolutely. That's a massive hygiene issue. If they don't know that they're clean, and they're out rolling around in their wheelchair or whatever, they have no idea, that can lead to a lot of skin breakdown, or, that they've soiled their brief or whatever, and it's sat on their skin so long, that can lead to rashes and skin breakdown and, infections. Big deal. Yeah, absolutely. I didn't know what you meant by water temperature, but being able to feel temperature, yeah. Why is it important for showering? Right. People can overheat in showers. I don't understand how, most girls can take it, shower and scald their bones. But, if somebody gets too hot in the shower, they pass out, hit their head, stuff like that. That actually happened to me. I had an inner ear infection, was in the shower. I couldn't feel the temperature on my back. I thought I had it all the way up. Never really could do that. I got way too hot, passed out in the shower. And that was all messed up. I had a vestibular system issue. All my senses were off. I didn't know. Totally healthy person, just had a little infection in my ear. Big deal, huge deal. If I would have been, older, fell in the shower, broke my hip, or hit my head, bleed out on the floor, and I wouldn't have, crazy stuff. All very good. Very good stuff. All right, so some overview here. Let's go to page 159 of how we test these kind of things. The little overview of it is, first, you're going to explain to the client why you're doing what you're doing, what is being assessed. Then you're going to explain to the client how it will be assessed and why you're assessing it. Okay? You're going to demonstrate the assessment first on your own body. You're going to practice the sensation test in 209. Okay? That's what this week is we're going to be doing. You're going to perform the evaluation on the client's unaffected side first, if they have an unaffected side, right? While the client keeps his or her eyes open for the practice, lastly, you're going to evaluate the affected side with his or her eyes closed. Okay? Very important to follow those steps. Why wouldn't you want to perform like a pressure test of sensation if the client's looking at it? It draws their attention. If you touch something to their finger and say, "Oh, can you feel it?" Yeah, I can feel it. That kind of deal. Some of the sensations that you do are very, 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 very light, but it is, if they can't feel it, it's a problem. Following those steps, okay, I want to read them to you one more time because those are very, very, very important, and it will come up in your practicals, okay? First, explain to the client what is being assessed. Second, tell them how it's going to be assessed and why you are assessing it. Third, demonstrate the assessment on the OT's body or your body yourself. Perform the evaluation on the client's unaffected side first, requesting that they keep their eyes open, and then last, do it with their eyes closed on the affected side. Okay? All right, so here's some different types of sensory tests. You have the light touch, sharp, dull, hot and cold. You have a stereognosis test. Write this down. Stereognosis is being able to recognize touch and sensation without seeing it, and being able to even say, "I know what that is." So I can look over here. I'm not looking at it. I can touch with my hand and say, "Here's the remote. Here's the power button." I can reach in my pocket and say, "Oh, that's a pen in my pocket." I can reach in down and, anything. Reach in, one common assessment used for stereognosis is we'll make like a mock woman's purse, have them reach in and say, "Okay, don't look, feel around, tell me what that is. Okay, pull it out. Tell me what it is." "Oh, it's a hairbrush. You said it's a thermometer or whatever." I don't know. Thermometer. It's cash. It's cash. No, that's not right. There's a stereognosis problem there. Okay? And then appropriate perception, kind of already said what that was, but that's awareness of where your body is in time, in space. Okay? Which table? Which ones? I don't know. What's on table 8 fell 4? You're going to go over those specifically in 209. Okay, the modalities class. It's matched up perfectly with this lecture. Cool? There is a lot on there. And you will have to perform these assessments in your next practical. Okay? And then perform them the right way, exactly how I told you. So I'm telling you, she is also going to tell you, and you're going to practice it. Okay? Gotcha. All right. So some treatment for sensory impairment. First, we need to talk about hyposensitive and hypersensitive. Hypo means what? Low, diminished. Okay, hyper means what? Too much. Okay, so your book's going to define it. A hyposensitive or sensitivity occurs when a stimulus is applied and the client does not feel it or perceives it as less intense than what it actually is. So someone might be able to feel something that is hot, but if you put their hand in boiling water and they're like, oh, this is just the right temperature, it's nice and warm, that's an issue, right? They can still tell it's warm, they just can't tell how intense it is. Hypersensitive is when you put something to somebody and it's like they way overreact. You might put it in like lukewarm water and like, ow, my hand, like it burns. Or if you put cotton up against somebody's skin and they're like, ow, that's like needles. You know, they can be very hypersensitive to stuff. This stuff sounds like it's not common. It's very common after stroke recovery, TBIs, things like that. Brain injuries are fun to work with. They can be very unpredictable too. Some of the things that we do is sensory re-education. This is where you're going to start with something like if they're hypersensitive, you might start with very soft textures and move your way into something more rough. Start with a cotton ball or even like a Q-tip and work your way to sandpaper or something. I mean, you're not going to rub but something rough feeling, right? Then you have desensitization, which is kind of the opposite of that. No, I said that. No, I didn't. I said that right. Desensitization is kind of the same thing, starting with a softer texture and working your way up with graded stimuli, something soft and moving your way up. And then comp strategies is the same pretty much as what we've talked about all over the place. Instead of wearing, if they really can't stand the feel of cotton, that it's just wear something else that's not cotton based. Okay? That sounds silly, but that's a huge comp strategy, right? If they have a sensory impairment, like they don't like the feel of certain things in their mouth, like mashed potatoes, okay? What's something that mashed potatoes is not a good one. They don't like the feeling of, chopped meat, okay? They don't like chicken or something like that. Downgrade something very soft, much softer, like mashed potatoes, Jell-O, things like that. Now you might get it like spit right back at you because they can't stand that feeling in their mouth, but you have to start low and work your way up. Okay? Sometimes, if they're hypo, you might need to start with something that is higher up. You might start with the sandpaper or the rough texture and work your way down to cotton if they can't really feel the cotton. Okay? Are we good? Cool. So we've talked about some motor coordination issues and we talked about sensory. That's two huge subjects. We're going to move to one more really big subject. Like I said, I don't know why this chapter is so all-encompassing. We're going to talk about wounds, pain, and motor controls Wednesday too. Are we good? All right. Lastly, we are going to talk about reflexes. Okay. Why do you think reflexes are so important? To help protect us. Where do you think they came from? Do you learn reflexes? They're just there, right? Why? You kind of touched on with it's there to protect you, but I mean, do you have to think about it when you go to fall to put your hands out? Or to step over to the left and help catch yourself? Do you have to think about any of that? Or if you touch your hand to the hot stove, do you have to think to pull it away? It's kind of there, right? There's certain primitive, very, very primitive reflexes we're going to talk about. I've got videos for these. This lady's voice, I apologize for it in advance, but they're really good videos, okay? The first one is the ATNR. I think this is on page 165 in your book. Yeah. This is the asymmetrical tonic neck reflex. Okay, this is with the client sitting or in supine or sitting. Client has their head turned to one side passively or actively. So it kind of looks like when you have their hand or head turned to their side, they kind of look like a bow and arrow. Okay, and then I've got videos that explain this way better than I ever could. Then you have the symmetric tonic neck reflex. That one's on page 166. So this is with the client in quadruped. The client's head is flexed or extended. And then you can see that movement there, what it kind of looks like. Like when they're back, it looks like this. When they put their head forward, their legs extend, arms come out. Okay? Symmetric tonic. I can never pronounce this. Yeah, that one. The TLR. That's what I like to call it anyway. This is where the client is placed supine or prone, with the client's with the head in mid position. Again, this is another one that the video is just going to break it down way better than what I ever could for you guys. The palmar grasp is one that's really easy to concept. I don't even have a video for it. You guys ever like put your had a baby or something, niece, nephew, or actual child, and you put your finger in their hand and they hold your finger like, "Aw." Sorry, that's a reflex. It's not special. Everyone does it. Sorry to break your hearts. That is your palmar grasp. That is a primitive reflex that we all have. You put your finger in their hand, and their natural thing, you put something in their hand, they grab onto it. I'm sorry to break your hearts. And then the Moro reflex, that one is on page 165. That's why the client is in a semi-reclined position. The head is dropped backwards. A position reaction is where they startle, such as abduction. That's kind of like a drop. I'll show you, and they flare their arms out. That one's kind of fun to assess. So anyway, let's go over these videos because I want you guys to see what each one of them look like. And these videos are on eLearn. So even if, later you can't, okay, I am actually going to stop recording too, because that is all the lecture part for today.